Welcome to the Hospital Medicine Unplugged podcast. Today, we're undertaking a deep dive into the evidence-based management of geriatric hip fractures, specifically proximal femur fractures. These remain, well, really one of the most clinically challenging and time-sensitive diagnoses we manage on the hospital medicine service.
Absolutely. The clinical urgency here is it's profound. When you consider the elderly patient population presenting with a proximal femur fracture, the statistics themselves really demand our focused attention. Despite all the advances in surgical and perioperative care, one-year mortality rates for these patients, they still approach 30%.
30%, that's staggering.
It is, and that burden is massive, both, for the individual patient who faces a substantial loss of independence and also on the broader healthcare system.
And that kind of statistic, which, as you say, is comparable to many aggressive cancers, it really defines the necessity of streamlined, protocolized, and proactive care right from the moment of admission. So our mission in this deep dive is to synthesize the most recent guidelines in literature. We'll cover rapid diagnosis, acute management, perioperative optimization, and crucially, secondary prevention, all tailored for the nuances of inpatient management.
Right, and to grasp the scope of this daily challenge, we first need to appreciate the epidemiology. We're talking about over 300,000 hospitalizations annually just in the U.S. due to hip fracture. The typical patient, well, they're often in their mid-80s, and the incidence just climbs exponentially after age 80.
And the demographics clearly point towards the underlying pathophysiology, don't they? Women account for, that 70 to 76% of all cases. That reflects the disproportionate burden of postmenopausal osteoporosis. And it's crucial to remember that the vast majority of these injuries result from low-energy mechanisms, just simple standing height falls, which really confirms the fragility of the bone structure we're dealing with.
Analyzing the risk factors is critical, not just for primary prevention out in the community, but because these factors really define our inpatient management strategy from day one. We can categorize patient risk into, non-modifiable factors, things like advanced age, female sex, a prior fracture history.
Things we can't change.
Exactly. And then the modifiable factors, which are really our targets in the hospital setting.
And on that modifiable side, as hospitalists, we have to focus intensely on underlying osteoporosis, nutritional status often reflected by low body mass index, maybe subnormal calcium, low hemoglobin, and perhaps most importantly, frailty and polypharmacy. I'm thinking particularly of those medications that impair balance or cognition, sedatives, and of course corticosteroids, which contribute significantly to both bone loss and fall risk.
And the compounding effect of the patient's environment is also very evident. It's worth just dwelling for a moment on the data for institutionalized patients, like those living in nursing homes. The annual incidence of hip fracture in this demographic can reach up to 6% in older women.
6% per year, that's incredibly high.
It's extremely high. And this vulnerability just underscores the necessity of aggressive fall prevention strategies and osteoporosis management long before the fracture ever occurs.
Okay, so we understand the scale and the risks. Now, since the anatomy dictates the surgical intervention and prognosis, the classification is far from just academic, right? We primarily divide these injuries into intracapsular and extracapsular fractures, and they tell two very different biological stories.
Absolutely. The intracapsular fractures involve the femoral neck and occur entirely within the hip joint capsule. The paramount clinical concern here is the integrity of the blood supply, the retinacular vessels that feed the femoral head. A fracture in this location, particularly if it's displaced, risks compromising that blood supply. And that can lead to potentially devastating consequences like vascular necrosis and non-union, which often necessitates reoperation down the line.
Right. Contrast that with the extracapsular fractures, which involve the intertrochanteric and subtrochanteric regions. These occur outside the joint capsule, and generally they benefit from a much more robust blood supply, so the risk of a vascular necrosis is lower.
However, the challenge with these extracapsular injuries, especially the intertrochanteric type, is that they are often far more comminuted, inherently less stable. The greater surface area and the force distribution lead to different biomechanical failure modes, and that necessitates different surgical hardware to fix them.
And this anatomical distinction, it translates directly to prognosis and resource utilization, which is really important for us as hospitalists when we're planning disposition. Data consistently show that these extracapsular fractures are associated with longer hospital stays, a higher short-term mortality risk, and a slower recovery of activities of daily living compared to their femoral neck counterparts. It reflects the greater trauma and instability.
So the clinical takeaway here is really clear. The first 24 hours must establish both the presence and the precise anatomical type of fracture. That's what initiates the appropriate operative track.
Okay, so anatomy sets the stage for rapid surgical planning. That means the acute diagnostic phase has to be seamless and efficient to uphold that critical 48-hour imperative we'll talk more about. The classic clinical presentation is textbook, isn't it? Acute anterior groin pain, inability to bear weight, and that characteristic shortened, externally rotated, and abducted lower extremity.
But, and this is a big but, we cannot rely solely on those classic signs, especially in our frail or cognitively impaired population. You, the listener, must maintain a high index of suspicion for atypical presentations. These patients might only present with vague pain localized to the buttock, the thigh, maybe even the knee or the back. And surprisingly, they may occasionally be able to bear some weight or at least ambulate partially. So a fracture has to be ruled out even if the patient isn't fully non-weight bearing.
So the imaging algorithm is designed for efficiency. First-line imaging is universally the antero-posterior, or AP, pelvis, and a cross-table lateral hip radiograph. These typically provide enough detail to diagnose and classify the majority of fractures we see.
The real bottleneck, though, occurs when your clinical suspicion is high, but the radiographs look normal, or maybe they're equivocal of the classic occult fracture scenario. Here, advanced imaging is mandatory, no question. We usually turn to computed tomography, CT, as the next step. Its main advantages are rapid availability and high specificity. It detects up to, 94% of radiographically occult fractures?
That's quite high.
It is. And critically, CT can actually change management in about 1/5 of these cases, often by revealing subtle fracture lines or displacement that you just couldn't see on the plain films.
However, we do acknowledge that MRI is the absolute gold standard for these occult fractures. So if the CT is negative, or if your clinical suspicion remains exceptionally high, MRI should be utilized. Even the abbreviated protocols offer nearly a 100% sensitivity. They identify bone marrow edema consistent with a fracture, even when displacement is non-existent.
Right. Its use is really prioritized in those highly suspicious cases, or perhaps when CT is contraindicated due to renal function or other issues.
Okay, so concurrent with the imaging diagnostics, a focused laboratory workup is necessary. This is for perioperative optimization and risk stratification. Required baseline studies are pretty standard. A complete blood count to check for pre-existing anemia or acute blood loss, electrolytes, renal function, a coagulation profile including PT, APTT, and a type and screen for expected transfusions.
And in addition to those baseline labs, we must use this acute window to start initiating the secondary workup for the underlying fragility. This can't wait until discharge. Secondary studies should include calcium and vitamin D levels because metabolic bone disease is really the core pathology here. Identifying and addressing subnormal levels early helps inform that comprehensive secondary prevention strategy we have to initiate before discharge.
It sounds like the entire diagnostic sequence is governed by the clock, the need to clear the patient for the operating room quickly.
Which brings us directly to perhaps the most critical operational constraint in hospital medicine for these patients, the 48-hour imperative. Multiple robust studies and major society guidelines strongly recommend early surgery, defined as occurring within 24 to 48 hours of admission. Why? Because it definitively improves outcomes and significantly reduces complication rates and mortality.
So this means our primary goal as hospitalists cannot be rigid, protracted medical clearance, but rather aggressive, targeted medical optimization specifically to facilitate timely surgery. But how often do we see unnecessary delays? For example, when an asymptomatic patient with an old, maybe mildly abnormal EKG gets delayed 12 or 24 hours for a routine, often low-yield echocardiogram, or a stress test that, frankly, isn't going to change the fundamental operative risk.
That is the precise tension the data highlights. Preoperative cardiac risk assessment must rigidly focus on managing active, reversible conditions. We need to aggressively optimize uncontrolled heart failure, stabilize unstable angina, or treat acute infections, because those are immediate, high-risk conditions that truly impact anesthetic safety. However, non-urgent, low-yield cardiac testing should absolutely not impede that 48-hour surgical timeline.
It seems counterintuitive sometimes.
It can feel that way, but the literature clearly shows that delaying surgery to pursue maximal but non-critical optimization often incurs a greater clinical cost than operating in a timely fashion. We really have to push back sometimes on that culture of medical clearance that risks turning optimization into unnecessary delay.
Okay, shifting gears slightly to another critical area. anticoagulation management. This feels like a high-wire act sometimes. We have to balance the immediate bleeding risk during surgery against the acute, very high thrombotic risk in an acutely immobile geriatric patient.
Exactly. Once the patient is stabilized and hemostasis is controlled, venous thromboembolism, or VTE, prophylaxis must be initiated immediately and then continued postoperatively. This is non-negotiable.
And this typically means bridging patients off their oral anticoagulants and initiating something like low molecular weight heparin, LMWH, such as enoxaparin or maybe fondaparin-X.
Right. And the specific timing of holding and resuming these agents is absolutely critical. It has to be coordinated meticulously with both anesthesia and surgery, especially given the increasing use of regional anesthesia techniques like nerve blocks.
Which brings us to pain management. This is another foundational pillar, isn't it? Critically important not just for patient comfort, but also, as you mentioned, for delirium prevention.
Definitely. The standard of care is multimodal analgesia. We start with scheduled acetaminophen, typically 3 grams per day, being mindful of hepatic risk, of course. That's our first-line systemic therapy.
And we have fantastic data now supporting the use of regional anesthesia as an adjunct.
Yes, techniques like the ultrasound-guided femoral nerve block or the fascia-iliaca compartment block are highly effective. They're proven to be associated with significantly reduced opioid requirements and, crucially, a lower incidence of postoperative delirium.
That fascia-iliaca block seems particularly useful.
It does. It tends to be favored as it can provide broad analgesia while potentially minimizing the motor blockade compared to some of the older 3-in-1 blocks.
Now, while opioids must be used judiciously, we also have to recognize that severe, uncontrolled pain is itself a potent, independent trigger for delirium and subsequent functional decline.
That's a key point. So, adequate controlled dosing of opioids is necessary to prevent severe suffering and, somewhat paradoxically, prevent the cognitive complications associated with extreme pain. It's a balance.
Definitely a balance. And finally, from the moment the patient arrives on the floor, we need to immediately initiate other complication prevention measures.
Absolutely. Structured delirium prevention protocols must be put in place immediately. This involves addressing sensory deficits, making sure they have their glasses, their hearing aids, promoting sleep hygiene, managing fluid and electrolyte balance carefully, and maximizing early mobilization as soon as possible.
And we also have to institute aggressive measures for pressure ulcer prevention. That means careful skin assessment right away and using pressure redistributing surfaces immediately upon admission.
It all starts right at the beginning.
Okay, let's move into the surgical phase itself. The choice of procedure is entirely tailored, not just to the anatomical fracture type we discussed, but also to the patient's biological age and their functional demands before the injury happened.
Exactly. So, for displaced femoral neck fractures in the elderly, arthroplasty or joint replacement is the standard. The choice then becomes between hemiarthroplasty, replacing just the ball part of the joint, and total hip arthroplasty, replacing both the ball and socket. Total hip arthroplasty generally offers improved long-term function and a lower reoperation rate for those healthier, more active patients who had a high functional status before their injury.
But there's a trade-off, right? Total hip arthroplasty involves a longer, more complex operation, and it carries a higher short-term risk of dislocation.
Correct. Therefore, hemiarthroplasty remains the preferred, often safer choice for the more frail patient, or those with limited pre-injury mobility or significant comorbidities. It prioritizes a shorter operative time and reduced immediate surgical risk.
Okay, what about non-displaced femoral neck fractures?
For non-displaced femoral neck fractures, provided the fracture is truly stable on imaging, the standard treatment is internal fixation. This usually involves placing multiple screws or a sliding hip screw device across the fracture. This preserves the patient's native hip joint, but it still carries some risk of the fracture displacing later or developing a vascular necrosis, which might require conversion to an arthroplasty down the road.
Now, when we move to those extracapsular injuries, the intertrochanteric and subtrochanteric ones, the hardware changes because the biomechanics are different.
That's right. For stable intertrochanteric fractures, a sliding hip screw remains highly effective. It allows controlled collapse and compression across the fracture site, which promotes healing.
But for the unstable ones, the comminuted fractures, or those with reverse obliquity patterns.
Right. For unstable, comminuted, or reverse obliquity intertrochanteric fractures, or for the subtrochanteric fractures, which are lower down, cephalomedullary nail fixation is generally the preferred technique. The nail functions more as an internal splint, a load-sharing device that better stabilizes the often comminuted medial column. It provides better fixation in that complex subtrochanteric region.
And that reduces the risk of implant failure.
Yes, it reduces the risk of implant failure and medial migration, which can sometimes occur with a sliding hip screw in these unstable patterns.
As hospitalists, we should also be aware that certain surgical techniques themselves can impact our perioperative management.
Good point. For instance, trials have shown that the use of cemented stems in arthroplasty, which provides immediate stable fixation, particularly in osteoporotic bone, can be beneficial. And also, the administration of tranexamic acid during surgery to reduce intraoperative blood loss has been shown to reduce transfusion requirements and potentially improve overall outcomes. We see that used routinely now.
Postoperatively, VTE prophylaxis remains an essential standard of care. We have to ensure robust pharmacologic prophylaxis continues for at least 10 to 14 days.
Yes, this usually involves low molecular weight heparin, fondaparinux, low-dose unfractionated heparin, or increasingly aspirin in certain protocols.
The inclusion of aspirin in VTE guidelines for the specific population reflects some recent data, doesn't it? Particularly from trials like APEX and P-Outcast.
It does. While LMWH tends to be slightly more effective overall, aspirin is often used, especially as a preferred agent for extended prophylaxis beyond the initial period, mainly due to ease of administration and lower bleeding risk in specific patient cohorts, though risk stratification remains key here.
And for high-risk patients, the decision to extend prophylaxis, maybe up to 4 weeks, should be strongly considered based on that persistent balance of bleeding versus thrombotic risk.
Absolutely. Now, the cornerstone of functional recovery, and arguably the single most important intervention the hospitalist facilitates post-op, is immediate, aggressive rehabilitation and mobilization.
Early mobilization has to begin on postoperative day 1, or really as soon as the patient is medically stable and cleared by orthopedics. Any delayed mobilization is directly linked to pretty much every major negative outcome we worry about.
Couldn't agree more. And for the vast majority of hip fracture fixations, weight-bearing as tolerated WBE is recommended. This is a crucial distinction from historical practice, keeping people non-weight-bearing for weeks. WBE facilitates that critical early mobilization, unless, of course, there's a very specific contraindication dictated by a highly unstable fracture pattern or the specific type of fixation used.
Good clarification. And finally, we need to address acute blood management post-op. Anemia is extremely common, both before and after surgery.
It is. For asymptomatic stable patients, the current transfusion threshold is generally a hemoglobin less than or equal to 8 grams per deciliter. This more restrictive transfusion strategy, guided by clinical stability and symptoms rather than chasing a specific higher hemoglobin target, has been shown to be safe and, importantly, avoids the risks associated with unnecessary blood product administration.
Okay, so as we transition towards discharge planning, let's pivot to the high incidence of complications we often encounter. It's quite sobering that nearly half of all hip fracture patients experience at least one complication during their inpatient stay.
It is sobering. We have to categorize these into medical complications, surgical ones, and the highly prevalent geriatric syndromes.
Let's start with delirium. It's arguably the chief concern, right? And a major risk factor for poor long-term outcomes, functional decline, and increased mortality.
Absolutely. Our prevention protocols have to be multi-component. We need optimal pain control, as we discussed earlier, meticulous fluid and electrolyte balance, maximizing that early mobilization, and critically, minimizing psychoactive medications whenever possible.
Specifically, benzodiazepines should be strictly avoided unless there's a clear, specific indication, like managing alcohol withdrawal or delirium tremens. The focus really needs to be on optimizing the environment and addressing the underlying medical precipitants of delirium.
Exactly. Now, in terms of common medical complications, we see things like VTE, pneumonia, UTIs, acute kidney injury, myocardial infarction, and pressure ulcers quite frequently.
So prevention requires constant vigilance, pulmonary hygiene to prevent pneumonia, prompt removal of urinary catheters to mitigate UTI risk,
meticulous skincare using pressure redistributing surfaces combined with frequent repositioning for pressure ulcers.
and AKI prevention hinges on maintaining euvolemia and avoiding nephrotoxins like NSAIDs whenever possible.
Right. And risk stratification for these complications needs to be ongoing throughout the hospital stay. Advanced age, male sex, a high ASA score, say grade 3 or greater underlying frailty, and critically, any delay in surgery or mobilization are all independently associated with an increased risk of poor outcomes.
These are the patients who require the highest level of management and resource intensity.
Definitely. Now, an absolute non-negotiable priority for the hospital medicine team before discharge is secondary prevention of future fractures. This is our opportunity to break the cycle of fragility. Every single patient who sustains a fragility fracture must be assessed for osteoporosis and have treatment initiated either prior to discharge or immediately post-discharge.
So this initiation of therapy involves ensuring adequate calcium and vitamin D supplementation first. We should generally aim for vitamin D levels greater than 30 nanograms per milliliter, which often requires high-dose supplementation in the acute setting. This needs coordination with orthopedics and primary care, of course.
Correct. And then bisphosphonate therapy drugs like alendronate or zoledronic acid should be initiated promptly unless there are explicit contraindications. Things like the patient being NPO still or having significant acute renal failure, typically defined as a GFR below 35 milliliters per minute.
What about patients who can't tolerate oral meds or are still NPO near discharge?
That's where we can use the hospitalization to plan for or even administer intravenous agents like zoledronic acid. Or we might consider alternative agents like teriparatide for the highest risk patients, particularly those with multiple previous fragility fractures or extremely low bone mineral density.
Furthermore, as hospitalist, we must ensure that the appropriate ordering of a dual energy X-ray absorptiometry, or DEXA, scan is completed. This formally assesses bone mineral density and guides long-term therapy, assuming one hasn't been performed recently.
This should be a mandatory component of discharge planning for every single patient admitted with a fragility fracture. It's just standard of care now.
Okay, the final aspect of the inpatient stay is disposition and discharge planning. This really has to be initiated from the time of admission, doesn't it?
Absolutely. Most of these patients, due to the profound functional loss, will require some form of post-acute care, whether that's high-intensity inpatient rehabilitation, a skilled nursing facility, or comprehensive home therapy.
And the evidence seems to strongly support high-intensity, multidisciplinary inpatient rehabilitation for appropriate candidates.
It does. That setting is associated with fewer poor outcomes overall, including a reduced risk of death or permanent institutionalization, and demonstrably better recovery of mobility and function compared to lower intensity settings.
So to ensure safe transitions, we need to confirm accurate handoffs to the next level of care. We need comprehensive medication reconciliation that explicitly addresses the continuation of VTE prophylaxis and the new osteoporosis treatment plan.
And we also need to ensure that home safety assessments and fall prevention strategies are initiated, either before discharge or immediately upon arrival home or to the facility.
And we should probably advise the patient and family that readmission within 6 months is unfortunately quite common, right? Most often due to medical causes like infections or cardiac issues rather than surgical complications.
That's an important expectation to set.
So, in summarizing the prognosis, we have to acknowledge the severity. We mentioned the 16 to 30% one-year mortality and the major functional loss that many experience. However, throughout this discussion, we've really defined the key levers for active intervention that lie squarely within the hospitalist's control.
Yes, the key prognostic factors are clearly defined by the data. Advanced age, the burden of comorbidities, underlying frailty, and crucially, the development of delirium or any delay in getting to surgery. Our ability to intervene effectively in the comorbidities, to prevent delirium through proactive measures, and to ensure timely operative intervention followed by aggressive secondary prevention, these are the most powerful forces we possess to change that trajectory.
Therefore, the final takeaway for you, the physician listener, is really the core message derived from synthesizing all this data. The timeliness of diagnosis and surgery, robust multidisciplinary collaboration involving orthopedics, geriatrics, and medicine, and proactive secondary prevention are the most powerful levers we possess for improving patient survival and functional recovery after hip fracture.
And this commitment to timeliness forces a critical, often high-stakes decision, particularly in that preoperative phase, that unavoidable tension between optimization and operating. We must continually reassess the long-term ethical and resource implications of potentially delaying surgery solely to achieve incremental, sometimes marginal cardiac stability, versus the proved mortality benefit of operating within that crucial 48-hour window. That risk-benefit calculation of optimizing versus operating has to be made in real time, always recognizing that delay itself carries a high and quantifiable clinical cost that often outweighs the perceived risk of the surgery itself.